Let's jump right into building a high-yield algorithmic decision tree for acute kidney injury. We're looking at pure Step 2 CK, next best step decision logic, mapping out exactly how you should evaluate a patient presenting with a sudden rise in creatinine. Here is our roadmap: AKI triage and resuscitation, pre-renal azotemia versus ATN, AIN and glomerulonephritis, post-renal obstruction, contrast-associated AKI, and rhabdomyolysis and dialysis. Starting with Section 1, AKI triage and resuscitation. Before we do anything else, we have to aggressively rule out immediate life threats. Remember, this algorithm starts right at the bedside, not in the lab. If your patient meets any of these criteria, you stop the diagnostic workup immediately and move straight to resuscitation or urgent dialysis. You're asking, is there shock, life-threatening hyperkalemia, pulmonary edema, severe acidosis, uremic symptoms, or a toxin ingestion? If yes, treat the emergency. If no, then we move down the algorithm. First up is assessing for volume depletion. Pre-renal AKI is driven by reduced renal perfusion. Now, this could be from true volume loss, decreased effective arterial blood volume in heart failure or cirrhosis, third spacing in sepsis or pancreatitis, renal artery stenosis, afferent arterial constriction from NSAIDs, or efferent arterial dilation from ACE inhibitors or ARBs. If you see evidence of volume depletion, give an isotonic IV fluid challenge and monitor the creatinine response before you even think about ordering a urinalysis. Moving to Section 2, pre-renal azotemia versus acute tubular necrosis, or ATN. If there's no clear volume depletion or the patient doesn't improve after that IV fluid challenge, we need to differentiate between pre-renal and intrinsic renal failure using a urinalysis with microscopy. For pre-renal azotemia, you'll see a BUN to creatinine ratio greater than 20:1, urine sodium below 20, a fractional excretion of sodium below 1%, and high specific gravity and osmolality with bland sediment. You fix this by restoring perfusion and treating the underlying cause. On the flip side, ATN is caused by tubular injury from ischemia or nephrotoxins. Here, the ratio is usually under 20, urine sodium is above 40, FeNA is greater than 2%, and you'll spot those classic muddy brown granular casts. Management here is supportive care, stopping nephrotoxins, optimizing perfusion, and monitoring electrolytes. And watch out for this classic exam trap: an ischemic story can still result in ATN because prolonged prerenal injury eventually causes tubular necrosis. You also need to keep the diuretic caveat in mind. If your patient is on a loop or thiazide diuretic, the FeNA becomes unreliable because it'll be artificially elevated. When that happens, look at the fractional excretion of urea instead. A few urea below 35% is what you need to identify prerenal physiology in these patients. Section 3, AIN and glomerulonephritis patterns. Let's head down the intrinsic branch of our algorithm and see how to tell interstitial from glomerular damage on urinalysis. Acute interstitial nephritis is usually triggered by antibiotics, NSAIDs, and PPIs, though autoimmune diseases and infections can also cause it. Don't wait around for the classic triad of fever, rash, and eosinophilia because it's actually pretty uncommon. On UA, you'll find WBCs, WBC casts, sterile pyuria, mild hematuria or proteinuria, and sometimes eosinophilia. The move here is to stop the offending drug and use glucocorticoids if it's severe or just not improving. But if you see hematuria, proteinuria, dysmorphic RBCs, or RBC casts, especially alongside hypertension or edema, that's a glomerulonephritis pattern. That requires a dedicated GN workup, not standard AIN management. Section 4, post-renal obstruction next steps. If the urinalysis is totally normal, we have to look for post-renal obstructive causes. Think BPH, pelvic malignancy, neurogenic bladder, stones, bilateral obstruction, or postoperative urinary retention. If your patient complains of lower abdominal tenderness, urgency, agitation, or an inability to void, especially right after surgery, your immediate next step is a bedside bladder scan. If you find significant urinary retention, you follow that up immediately with a urethral Foley catheter to decompress the bladder. Knowing the exact cutoffs for post-void residual volume is what dictates your management here. Normal is 150 milliliters or less in women and 50 milliliters or less in men. If the scan shows retention above these numbers, put the catheter in. If there isn't significant bladder retention, but you still suspect an obstruction higher up in the urinary tract, your next best step is a renal ultrasound to check for hydronephrosis. Section 5, contrast-associated and crystal-induced AKI. We're pivoting now to specific iatrogenic insults that cause predictable acute kidney injury, specifically contrast administration and crystal-forming meds. For contrast-associated AKI, you must memorize this timeline. The initial rise in serum creatinine happens 24 to 48 hours after giving arterial contrast, and it gradually returns to baseline within 3 to 7 days. This specific kinetic profile is what differentiates direct contrast tubular cytotoxicity from other nephrotoxins, which usually take a week or more to show up. Key risk factors include chronic kidney disease, diabetic nephropathy, hypovolemia, NSAID use, and a high volume of contrast. You prevent this by optimizing renal perfusion with IV isotonic saline before the procedure, holding those NSAIDs, and keeping the contrast volume as low as possible. And watch out for this classic trap. Holding metformin in these patients is done strictly to prevent lactic acidosis from drug accumulation. It does absolutely nothing to protect the kidneys from the contrast itself. Then we have crystal-induced AKI. Common triggers include acyclovir, sulfonamides, methotrexate, ethylene glycol, and uric acid from tumor lysis syndrome. This typically presents within 7 days, with hematuria and visible crystals on the urinalysis. To manage it, you stop the offending drug, aggressively replete their volume, and give a loop diuretic. Section 6. Rhabdomyolysis and dialysis indications. Let's look at one of the most dangerous causes of intrinsic renal failure, pigment nephropathy from rhabdomyolysis, and exactly when you need to initiate dialysis. Rhabdomyolysis is the lysis and necrosis of skeletal muscle. It can be triggered by crush injuries, prolonged immobilization, seizures, intense exertion, cocaine, amphetamines, alcohol, colchicine, or drugs like statins and fibrates. This muscle breakdown is highly toxic to the kidneys and causes pigment nephropathy, which means it requires immediate, aggressive intravenous fluid resuscitation. The big diagnostic trap to watch for is a strongly heme-positive dipstick, but an empty microscopic field with few or no actual red blood cells. That points right to myoglobinuria. You'll also see a massive creatinine kinase spike above 1,000, an AST higher than ALT, and the highly dangerous electrolyte profile. As muscle cells lyse, they dump potassium and phosphate into the blood, causing hyperkalemia and hyperphosphatemia. Meanwhile, calcium deposits into the damaged muscle, leading to hypocalcemia. You have to monitor these patients aggressively for compartment syndrome and fatal hyperkalemia. When aggressive fluids and medical management aren't enough, like in severe rhabdomyolysis or severe ATN, we use the AIOU criteria to dictate the immediate initiation of urgent dialysis. A is for acidosis, specifically a pH below 7.1. E is for electrolytes, like symptomatic hyperkalemia above 6.5 or with ECG changes. I is for intoxications, from lithium or toxic alcohols. O is for volume overload, that's refractory to diuretics. And U is for uremia, causing encephalopathy, pericarditis, or bleeding. Recognizing when to stop medical management and start dialysis is the ultimate next best step in managing acute kidney injury.